Hi, my name is Carrie Schmidt. I'm a doctor of physical therapy. I am here at Dr. Jerry Hirsch's seminar for the SIJ and lumbosacral pelvic class. I initially, when I was young, I was in a traumatic car accident. When I was 18, I had bilateral fib, femur fractures, and over time, I've had multiple surgeries, more than 37, I lose count after that. And obviously, I have chronic issues orthopedically with my hips, knees, and ankles. Actually, in the initial accident, I severed my Achilles on the right posterior and the lateral part of my ankle. I also severed the peroneals. So initially I had foot drop because I had no muscular control. They initially treated that with an AFO, and following, I seemed to gain some muscle control. When I did, when I started to ambulate and gait train, actually my muscles had tightened and shortened and my foot pretty much fused itself. So since that time, probably since 1995, when I walk, I only have initial contact in my right calcaneus. I have mid stance, but I do not have push off because I do not have the gastroc firing when I walk. So obviously that I demonstrate a limp, or wouldn't say it's an antalgic gait because it's not really painful. So moving on to recent, about 3 years ago, I had osteomyelitis I found in the medial calcaneus on the right side. Keep going.
Keep going. You're good.
I was treated with IV antibiotics, hyperbaric. It had gone away. In that time of getting the osteo, I presented with a stage 4 pressure ulcer. My entire calcaneus was open to the bone. So within that, I did wound care, I did hyperbarics, and I did IV therapy. Everything started to close up and heal, and again, it happened probably about 6 months later, same course of treatment, and it happened again in December of 2014. So I finally went to my orthopedist, and he removed the infected bone. When I walk and weight bear, I place all of my pressure on the medial aspect of my heel, and so the medial aspect of my heel, and again I have no push off, so every step I take I'm putting 100% pressure on my heel during gait. So I came to this course because I love the SI, I love everything about the pelvis, and I know I didn't have enough information about that to apply it to patients. So as I came here, Dr. Hirsch was interested in assessing my condition, so he assessed me as a whole. He first checked my right ankle, and because of the fusion, or not technically a surgical fusion, but a physiological fusion, he was unable to do any manual therapy at the knee. So in turn, he checked my femur and my pelvis. My pelvis exhibited a right downslip with my femur placed posteriorly. So Dr. Hesch was able to correct that with a correction of the downslip, and also applying an anterior force to the femur to reset how the hip was fitting in acetabulum, and also how the ilium was back forward, how my ilium was forward. In doing that, prior to the treatment, when I would ambulate, because I had only initial heel strike, I also had excessive internal rotation on my right hip, which caused me to trip, because my my foot would internally rotate where I was actually tripping with my left side. So after treatment, I actually noticed a huge change where I'm able to keep my foot and leg neutral during ambulation, where it's not internally rotating and I'm not tripping. Also, another plus that I've noticed is during ambulation, I feel lateral pressure during gait, not just medial. So that allows me to unload the pressure on the medial aspect, in turn, in future, allowing my wound to heal.
Your husband and your fiance and your mother made comments.
Oh yes. Actually, I was so excited about the results when I left here yesterday. I just couldn't believe that my foot is actually facing forward, and I'm like, all right, this is going to be a fluke. It's going to change. It'll go right back to where it was. So I stopped over at my mom's house, and I'm like, you're not going to believe this. You're not going to even believe what's going on. So I showed her, and she's in shock because, again, I've been walking like this for almost 20 years. I've had the same gait, and within minutes, I have not, I wouldn't say a normal gait because I don't have push-off, but I do have a neutral foot, and I'm not tripping over it on my left. And also, when I got home, I showed my boyfriend, and he was in absolute shock. He actually said, because I thought I limped really bad, me as a physical therapist, I said, okay, I have no push-off, so that's obviously what's causing my limp. He said, as a layman, looking at me, what he noticed is when I was walking, that my foot was turning inward, and that to him was catching his eye as an irregular gait, not the actual push-off phase. So now, when I ambulate, my foot is actually facing forward, so to me, you notice less of a limp when I ambulate.
So you feel like you're safer now?
I feel like I'm a lot safer. I have tripped multiple times. I've tripped in the clinic. I've written incident reports. I've had some pretty bad falls, especially when I would try to ambulate quickly or, walk fastly, when you're in the clinic and hot packs doing whatever, going back and forth. You're not really paying attention to how fast you walk.
Yeah, and the incident report, your manager said you got to fill this out because you fell in the clinic.
Right, exactly,
Right.
And that happened at least 2 to 3 times.
To cover.
So to me, it wasn't a big deal because that's my gait, but in the other sense, it is a big deal. You shouldn't be falling and injuring yourself just during normal ambulation. I'm not tripping over an object on the floor. The surface wasn't uneven. It had fully to do with my internal rotation of my right hip.
Very good. So I thank you for sharing your story.
Of course.
And I had no idea what I would find in screening you. And of course, hope of hope was that I would be able to help your ankle, and was not able to affect that at all. I mean, that joint is fused, and it was at the knee joint that we glided femur anteriorly. And then in the pelvis, you seemed to have a downslip, and sacrotuberous ligament was taut. There was no vertical mobility. Restored that, and that allowed your nervous system to engage your stabilizers in the transverse plane of the hip. Mm-hmm. And so I'm very confident that that will last. And if we haven't covered it yet, we're going to cover how you can self-manage it.
Oh, I will be
manage
doing
it.
that.
So this is a one-time treatment. The rest you'll be able to maintain that benefit.
And the treatment was modified slightly because of my injury at the bottom of my heel.
That's right. That's right. Yeah.
So you did it in side lying versus normal would be in a supine positioning.
So what's your outlook with respect to the issues with gait?
I want to maintain everything that I've gained in this last 24 hours and have it throughout life, because if this will make big changes in my life with gait and just even with the pressure that I'm putting on my heel, because I've been in a compromised position for over a couple years. I don't know if you know, when you have a wound, you're only at 80% capacity in a short period of time, and that's not into a chronic wound. Unfortunately, I've been into the chronic wound phase, so I've gotten to the point where I don't have fat pads and fatty tissue. So for me to be able to do weight distribution is the only way that I have chance for a correction.
So we have a case of osteomyelitis in the right heel, and as part of that car wreck, you fractured 2 femurs, 2 tibia.
Two fibulous.
Right, and there were other things that happened, with the medical emergency taking precedence.
Right. Their concern at the time wasn't so much, it was saving my life. It wasn't initially they wanted to amputate it. It was all about, I severed the femoral artery, and it was all about, I coded a few times. It was just about keeping me alive for the next 48 hours and getting out of the woods, and then they would really address. And again, at that time, it was big structures. It was the bones. It was this. They're not worrying about ligaments. They're not worrying about muscular tendons. That's not their concern. Their concern is fixation and hopefully having a future of being able to walk again.
And so so now at this stage, a full body examination giving consideration for unusual, unpredictable things, we were fortunate enough in being able to find that you had what we name a downslip of the ilium, which is a rare phenomenon. And whatever it is, and this is not a research lab, we don't have a CAT scan, a 3D CAT scan that look inside your body while I'm treating you, but the neurological effect is what you spoke of, and that was very definitive. And so I'm probably answering my own question. The whole body screen in a situation where there's a medical condition and an orthopedic condition probably makes good sense.
Makes great sense, especially in a overcomplicated trauma case like me. It's almost sometimes overwhelming. I've gone to some doctors and they're like, why are you here? I don't know what I can do with you. So to address my body as a whole versus pieces functionally is the best outcome that could happen.
And I've been interacting with you for a day and a half now. At no time would I ever make any assumption. I would never know that you had this kind of disability, other than your language and then watching you walk and screening your body. I mean, your manner of interacting with your disability is remarkable.
You do what you gotta do.
Yeah, well, thank you very much for sharing that. I truly appreciate it.
No problem.